please, when you join, mute yourself. Let's do that. So as soon as you join, please mute yourself. Just we have a lot of people here. Chat in your name. If you don't have access to the chat, you're also welcome to just come off mute and share your name. Anytime anyone speaks, and this is for all of our speakers, please introduce yourself so everybody knows who's speaking. So say your name and your role. For any time we share, just a reminder, speak for yourself, use I statements. If you would like to speak or you have a question, we invite that. Please raise your hand, either using the menu at the top or just actually raise your hand in the video, because we can see you most of the time. For anyone who would like to use it, there's closed captioning. It's in the more of the toolbar, and then you just turn on live caption. You can choose the language that you'd like. And just a reminder for anyone who would like them, we send all of our notes out in text-only format. And then finally, I want to say we record this meeting and we post it on the internet. So if you don't feel comfortable being recorded, unfortunately, we would just like to ask you to leave in the most gentle way possible and encourage you to watch the video on our website. So those are our meeting norms. And then we're going to go to the next slide. A reminder for everybody here, this is the health department's vision and mission. Really what we're about here at the health department, and really what drives the work of the Local Health Improvement Coalition, is a just and well Baltimore, where everybody has the opportunity to be healthy and to thrive. You can go to the next slide. A reminder about the values that drive the LHIC and the work at the health department. We strive to be data-driven. We want to be full of integrity, and we want to be innovative, collaborative, and empowering. For folks who are new or possibly just want another reminder about what the LHIC is, so the Local Health Improvement Coalition is not a state requirement, but it's a strong recommendation to bring together a diverse set of multi-sector groups, so people from different types of roles and positions, perspectives in the city, to identify and address our most pressing health priorities. We know that to address some of our biggest challenges, we need to have shared leadership of government and community. And so that's why we brought together the Local Health Improvement Coalition. Our current work is focused on diabetes, care coordination, and social determinants of health, sometimes also referred to as social needs. You can go to the next slide. Before well, let me go through this agenda first. So what we're up to today, one is we're doing introductions, and then we were going to hear from our health commissioner, Mary Beth Haller, but she wasn't able to join us today because there's some emergencies. And so Dr. Green will be making the announcement on her behalf. And then we're going to hear from a slew of health department staff. Dr. Green's going to give us an update about the community health needs assessment. I'm going to do another reminder about Medicaid enrollment. Stefan, our LHIC coordinator, is going to talk about community member recruitment and updates. And then Sadia McKeith, actually, who's not here today, so I'm going to present on her behalf, is going to, I will speak for her around the Policy Learning Collaborative. Then we're going to hear from all of our folks in our priority areas. So for the social determinants of health, we're going to hear from Kiana Mayo, Dr. Teresa Leslie, and Rashad Staten. For citywide care coordination, we've got Diana Quinn from MedStar here to talk about some of the work they're doing around social needs screening and connecting people to the resources that they need to be healthy. And then for diabetes, we actually have 3 presenters, and so we're really looking to those folks to be seamless and on time. And so we've got Pam Sinakis from...
And sorry to cut you off, but Pam says she was running a bit behind, but she is on her way to join the meeting.
No problem. Thank you. So we'll hear from Pam, Alice Chan, and Michelle Peralta about diabetes. And then finally, for the community spotlight, Dr. Ugbalu is also not able to join us, but in her spot, we've got, I believe, Janet North Kilborn, and I think another presenter whose name, I'm sorry, escapes me at the moment, but we've got some stand-in presenters for her. And then we'll wrap up with some community announcements.
Oh,
Please. Someone about to jump in about the presenter for Community Spotlight? Okay, so that's what we're up to today. And then just a couple of quick housekeeping items before I hand it off to Dr. Green for the welcome. So moving forward, we are going to starting on time. We usually have given people a grace period of about 5 minutes before we got started, but moving forward, we are going to start exactly at 9 o'clock because our agendas are increasingly getting packed. I want to also say to all my speakers, and we have quite a few both at the health department and our external collaborators here, please, when you have your section, please first introduce yourself. So say your name and your role so everybody knows who you are. And then keep an eye on me. I'm going to help everybody stay on time. So Stefan and I will be timekeeping. And so if you're wondering how much time you have, I'm going to give you a signal at 5, 2, and 1, just so we can kind of make sure we get everybody through. I'm going to be gracious as usual, and people are going to get an extra minute here and there, but I just want to try to give enough time for all of our speakers. And then the last housekeeping thing that I want to share, and this is really more of an announcement. This is good news. We have long sought a local health improvement coalition manager, and we've got that person now. So I'm happy to announce that we have Michelle Peralta with us. Michelle joined the health department a few years ago. She joined us to work on the COVAX response. She did that work, and then she's been working on my team, leading the Health Disparities Grant. Some of you have probably heard about this grant. It's a mini grant program along with some other work that she's been leading, and we thank her for that. And now we're very, very excited to have her as the LHIC manager. Michelle's going to oversee a broad range of things in the LHIC, but right now what's most relevant are 2 key initiatives on our diabetes work. It's around outreaching people for DPP programs, and around some education for children around diabetes. So it's good to have you, Michelle, and thanks for joining the team. And just so you know, everybody will hear from Michelle later today. Those are my announcements. Anything else from my team before I hand it off to Dr. Green? All righty, Dr. Green, aka Mary Beth Haller, go ahead.
Great. Thank you, Elise. Good morning, everyone. Like Elise said, our acting commissioner, Mary Beth Haller, was not able to make it to this meeting. A little bit of feedback, so we might have to mute somebody. But
yeah, let's just a reminder to mute. I'm sorry, Dr. Green.
No, you're fine. Oh, yeah, it's gone now. But I just wanted, on her behalf, I wanted to say hello and welcome to all of our LHIC members for joining us today. We are looking forward to your participation and your support during our Community Health Needs Assessment, also known as the CHNA. And as you know, the CHNA happens every 3 to 5 years, and it is a requirement for our public health accreditation. This year's assessment will help us set health priorities for the city and also help shape our community health improvement plan. Your input and participation are very crucial for the assessment and plan. So please look towards your emails for information on how to get involved and how to get community members involved. And we'll review that a little bit later as well. I also wanted to say congratulations to our LHIC team for getting a diabetes grant. It will be $1 million each year for the next 5 years, and it'll allow us to support the diabetes work and some of the diabetes education within the city, as well as support the work of our community health workers. So we're really looking forward to that project as well, and we'll probably be reaching out to several members of the LHIC community. But again, I wanted to say thank you for your support. Thank you for your energy and your commitment to this coalition. And we'll revisit the CHNA in just a few minutes. So we can go to the next slide.
Great, thank you. So now we're gonna hear from a slew of folks at the health department, and we're actually gonna hear from Dr. Green again. So back to you,
Oh,
Dr.
that's
Green.
true. Oh, yeah, we could have skipped that one. Sorry, everyone. Well, welcome again. My name is Tamara Green. I'm the Chief Medical Officer for the Baltimore City Health Department. I will briefly review the Community Health Needs Assessment and then also introduce Emily McCullum, who is the strategy manager for the Community Health Needs data collection partner that we have for the project. As already mentioned, that the CHNA is a joint effort between the Baltimore City Health Department as well as the city health systems, and it'll help set our priorities for um, projects and resources in the community health improvement plan going forward. We can go to the next slide. So this is the timeline thus far, and the data collected from the surveys and the focus group will again help shape our community health improvement plan. Important to note on this table is that July, we already started. Right now, what is open is the community survey. It's open until November 3rd. And also the key informant survey, which is really the key leader survey. So a lot of people on this call will fall under that category, and we can go into that a little bit further. But we have a link and we have a QR code. So it's a survey of questions. We want to get your input. We want to have you share your knowledge about what you think are the health priorities of the city should be going forward. Next in October, focus groups will be held as well. And then as you can see for the remainder of the year and then going into February and March of next year, we'll be able to review the data that's been collected and then draft a report after we analyze those findings. And so you can look forward in March 2024 to the final report. And with that, go ahead.
I apologize, Dr. Green. May I just make a note for this group that if you see in December prioritization of data findings, the Local Health Improvement Coalition is going to play a role in that. So this is just to bring that to everyone's attention. We will be reviewing data and talking about how we want to prioritize it, both in this meeting and in our monthly meeting. So just making sure that's clear. And sorry for the interruption.
Oh, no, thank you for highlighting that. And I would turn it over to Emily McCullum of Ascendiant if she is on the line. I think so.
I am. Thank you, Dr. Green, and thank you all for letting me come speak to you here today. I'll try to keep this brief because I know you have a lot to cover. But my name is Emily McCallum. I am a managing consultant with Ascendiant Healthcare Advisors, and we are a consulting firm. Our main office is in Chapel Hill, North Carolina, and that's where I'm based out of. We also have an office in Washington, D.C., and we do a lot of work in the public health sphere, a lot of work around community health needs assessment. We do a lot of work in rural healthcare, kind of trying to help keep rural facilities open. But we have been contracted by the Baltimore City Health Department and a collaborative working group of folks from hospitals and health systems all across the city of Baltimore to run this year's community health needs assessment. So what we're really doing is kind of coordinating things behind the scenes, bringing that group together on a monthly basis to really talk through what the data says, talk through some of these primary data collection activities that I'll talk about a little bit more in a second, and really work on identifying those priorities. And Dr. Green gave a great explanation of what the community health needs assessment is and why we do it, so I won't go too much into that. But what we've been doing kind of behind the scenes on our end, we've been looking at a lot of what we would call secondary data. So those data sources you might be able to find through the CDC or the Maryland Department of Health to really paint that initial picture of what things are looking like in Baltimore City as far as health outcomes, as far as social determinants of health, all those things that impact the ability of residents to live their healthiest life. But we know that those data sources are usually a little bit outdated. We want to make sure that we're actually getting the perspective from the people who are living and also working with the communities in Baltimore City. So through that, we have a few community engagement activities, and I just wanted to kind of mention them a little bit, let you know how you can kind of help us out with this data collection process, and then I'll open it up to see if anybody has any questions. So we have 2 web surveys, as Dr. Green mentioned. Those are both open from now through November 3rd. So we have one that's really targeted to community members, and we're really looking to get a diverse perspective from folks that do live in Baltimore City, and we want to understand what they're experiencing in their neighborhoods. What are they seeing in their daily lives? What are those health and social needs and what are the resources that they think, could really be developed to help address those needs. So that top link there, and then that QR code is for the community member survey. If you are an engaged community member who's on this call today, I would really encourage you to take that survey and provide your feedback. It's going to go a long way in helping the health department and all of the hospital partners really help develop those programs and services to address the needs that we'll be kind of prioritizing later on in this process. If you are what we would call a key leader or a key informant, so somebody who works for maybe a nonprofit organization, works in healthcare, works for a faith community of some kind, we really want to get your perspective as well. So that second link and that QR code is for our key leader or our key informant survey. So we'd really encourage you to take that survey and give us your perspective as somebody who's actually directly involved in working or providing services to the community. To that point, for our key leaders that are on this call today, if you have opportunities to share with the community members that you do work with the links for that survey, we would absolutely love if you could kind of share that. If you have community events coming up, flu shot clinics, things like that, anywhere where you're kind of engaging with the surveys, we would really love to boost our engagement and really just get as many perspectives as we can from residents in the community. And then Dr. Green did also mention a little bit about focus groups. Myself and my colleague Brian Ackerman are going to be coming up to Baltimore the week of October 16th to run a whole bunch of focus groups, and we're still working on coordinating a handful. So I am pretty sure I've seen some names on this call of folks that I've probably been, filling up your inbox with emails over the last couple of weeks. So keep an eye out. I might still be, reconnecting with you just to kind of iron out the final details there, so we can get as many different focus groups as possible. Because really, at the end of the day, these community engagement activities are really critical in actually painting a picture of what really is happening in Baltimore. We know that the data doesn't always tell a complete picture and doesn't always give us that perspective. And so we just want to make sure that we're really covering as much ground as possible on that front. And then just a couple of notes on survey data. All of the responses to both surveys are anonymous, so we are not going to be reporting out any individual answers that anybody's giving. That will all be kept confidential, but we are going to be kind of aggregating all this data and sharing some high-level results, and that will all go into the final report for the community health needs assessment. Those will be made available through the health department and through hospital partner websites sometime next summer. So you can all keep an eye out for that. So with that, I would love to hear if we have any questions or if anybody has any thoughts about the survey. I'm happy to answer those.
We have 2 minutes for questions, so if anyone wants to come off mute or raise your hand.
And I will say too, my email address is right there on the slide, so please feel free. Oh, Lorena, I see your hand is up.
Yeah, I just had a question I had actually thrown in the chat, but you mentioned that the community health needs assessment participants would be the health systems, and will the MCOs also be included? Because we're the ones who actually service a lot of these needs as well for the community. So I was just curious if we'll be involved in the China as well.
So my general understanding is these hospital partners are fulfilling a regulatory requirement. As nonprofits, they do need to submit this kind of information to the government on every 3 years, and so I think that's kind of where they're the primary funding partners for this. But certainly, we welcome any participation through surveys and any kind of additional feedback that you would like to have included, as well as if you have data that you think paints a picture of some of those health needs, you can feel free to send that to us, and we're happy to evaluate that and kind of include it in the prioritization process as well.
Okay, thank you.
Mm-hmm.
We have someone on the phone as well. Thanks, Lorena. One other question. Okay, maybe we lost that person. Any other questions for folks? I don't think we're going to get any other questions. Emily, if you have any. Oh, here we go.
Yeah.
No worries. Go ahead.
I'm Marguerite Woods, and I'm a community stakeholder. And my question is, how do you engage people who don't have access to the internet to do the survey? who live in the community and could definitely have opinions about what they think could improve the health or what the health concerns are.
That is a very good question. So we, on our end, are kind of leaving it to our community partners to really engage with the community in the way that makes the most sense. So we have provided to several of the hospitals and health systems, as they've requested, a paper version or a PDF version that they can print out so they can actually go out into the community to engage with folks that may not have reliable internet access or may not be, having that high level of literacy to be able to complete the survey. So there are some kind of boots on the ground efforts on that front that I'm aware of. And I will note also that the community member survey is available in Spanish as well as English.
Is there a way to find out where in the community they would come, or can you request that they come to certain areas or community centers or?
Yeah, I think there's probably some opportunity for providing some of that feedback maybe to Dr. Green's team, and they can, notify the appropriate hospital partners who might be able to more effectively, reach out into those communities. But really, we're kind of leaving all the distribution efforts up to our funding partners, which is the health department as well as all of the hospital and health system representation.
Yeah, may I jump in here on this really quick? So we would actually love to hear from you about this. And so Stefan, please reach out and let's get some of your feedback. And then from Marguerite, and we can share that with the hospital systems in our standing meeting. I also really like your idea about being more clear about where and when we're going to be distributing the survey. So let's be in touch, and then we'll get your feedback and share it with our larger stakeholders.
Absolutely. And I'm thinking about homeless people as well.
Yeah.
How do you get their feedback?
Yeah.
We
Thank you for that. I appreciate it. So we'll get more of your feedback and share that. I'm going to move us on. Unfortunately, Emily, we've got a few things in the chat for you to follow up on. I do want to say that MedStar goes out into the community with their purpose surveys, and Erica's requesting the survey in Spanish. I think we can share that out at the end of the meeting, Erica, just so you have access to that. And then Marique has a question, Emily, that I don't know the answer to, but we can follow up with you, Marique, and I'm not sure about that.
I'll go ahead and follow up in the chat so you can all kind of move on with your agendas. But thank you all so much. It was really lovely to be able to come here and speak to you this morning. So thank you.
Right. Thank you, Emily. And thanks for those great comments and questions. Okay, let's go to the next slide, please. Here's a quick update from me. We can go to the next slide. So I wanted to share this again. I think we've shared this several times, but it's important that we continue to share it. This year, Medicaid does not automatically re-enroll folks as it did for the previous 2 years. We know that dozens or hundreds of people in Baltimore City and in Maryland don't have their Medicaid. And so I want to make sure everyone is aware that if you're working with someone who is Medicaid eligible, or if you yourself are Medicaid eligible, you need to make sure your contact information is up to date. More importantly, we do have a resource in the city, Healthcare Access Maryland. Their information here is on the slide. They can help anyone who has either lost their Medicaid or needs help to update their Medicaid information. They can make the phone call for them. They can provide them with the support. Healthcare Access Maryland's phone number is 410-500-4710. And there's some prompts when you call in that will help you find the person that you need to support you. Alternatively, if folks want to do this on their own without the support of Healthcare Access Maryland, you can go to Maryland Health Connection, where you can update your information. I do also just want to say that if you lose Medicaid coverage, you have 120 days to re-enroll. And so just keep that in mind when you're reaching out to folks and or for yourself, so that folks don't lose their Medicaid. We know it's an important benefit. That's all I have on that. And well, one final thing is we will be sharing out some flyers about this at the end of the meeting, including the information on this slide. Okay, we can go to the next slide and I'll hand it off to Stefan.
Hi everyone. Just trying to put out a fire with the waiting room. There's something going on to where it is not allowing us to accept any new people, but we are aware of it and are trying to fix it. Matt, go ahead to the next slide. So as you know, we've started this initiative trying to recruit community members because obviously we want the community voice at the table. And so we've been lucky enough to secure a pot of money that allows us to compensate community members for their participation in the LHIC. So as you can see, some of the highlights from this initiative, it's a $30 stipend for each hour of participation. Realistically, we can expect community members can expect to participate about 4 to 10 hours a month. We are seeking representation from these groups, or older adults, youth, people living with disabilities, the LGBTQIA plus, and so that these are preferred populations, but not required. Obviously, we would want folks to be a Baltimore City resident, have an interest or passion for addressing diabetes, social determinants, or care coordination, desire and ability to work on diverse groups with long-term goals, and ability to think about big problems and offer solutions. Um, I just want folks to be like reminded of sort of, why we're doing this. I know it's because obviously we want the community voice at the table, but there's definitely a bigger why there. So if we could go to the next slide. And so these are, when we think about our why, um, you know, representation and equity, right? Communities are diverse and their needs and concerns and experiences vary widely. So by including that community voice, we ensure that the perspectives of marginalized and underserved populations are taken into account. And so this helps promote health equity. Um, cultural competency. Communities have unique cultural practices, beliefs, traditions that impact health behaviors and outcomes. So involving community members in these discussions about public health allows for a better understanding. It's mutual. It helps them express their needs, and it helps us understand those needs. Local knowledge, obviously, they possess communities possess specific knowledge about the communities that they live in. That is that lived experience that we are are looking for. And so this knowledge can inform the design and implementation of effective public health programs and policies that are tailored to specific needs of the community. And community engagement, when communities are actively engaged in public health discussions, they're more likely to take ownership of health initiatives. There's that buy-in there that we always talk about. Um, trust and credibility. Trust is a critical component of any successful public health effort. Community involvement builds trust, between public health officials, healthcare providers, and the community. So again, when they have when community members have that voice in the decision-making process, they're more likely to trust recommendations and guidance. Um, effective communication. Community members often have insights into the most effective ways to communicate health information. There's sort of what we've learned in our career, what we've learned during our education, but it doesn't always translate to practical real world knowledge. And having that community voice kind of helps us, cultivate that. Um, Identifying priorities and gaps. Communities can provide valuable input on their most pressing health concerns in areas where they perceive gaps in services. So we can't know what's, in order for us to be able to support, it helps to know, where these gaps in services lie. And accountability, right? They hold the community will put our feet to the fire, Involving the community in these the discussions fosters transparency and accountability in the decision-making process. When they're made openly, it helps prevent mistrust and skepticism. When we do come with these initiatives. And finally, community resilience. Empowering communities to have a say in public health matters can build resilience. When they're involved in planning and responding to health crises, they are better prepared to adapt to changing circumstances and mitigate the impact of these health emergencies. Just thinking back to the pandemic, like how much of a better response would have been if there was more if community just in general were just better informed. And I'd actually like to add a number 10. It's not on this slide. Having the community at the table, they serve a constant reminder of why we do the work that we do. Whether we're battling burnout, questioning our impact, or maybe even questioning our purpose, we must always remember what called us to this career, right? We are in the people business, and we should always put the people first. So I will leave you with this Chinese proverb about happiness that I came across. It goes, if you seek happiness for an hour, take a nap. If you seek happiness for a day, go fishing. If you seek happiness for a year, inherit a fortune. But if you seek happiness for a lifetime, help others. Thank you.
Thank you, Stefan. Appreciate that. Betsy, I think, has a question. Betsy, do you want to ask your question quickly?
I can ask it quickly. This is Betsy Simon, BDS Healthy Aging Network, CEO and founder. My first question is, I've been actually circulating your requests for people to join. Is this ongoing? Shall I leave it up? We send our mailings out to about 500 every week. And it's been ongoing. And the second question is, I really like your added bullet. Will you all consider having an open forum for residents and older adults and all populations, at least quarterly, so people can hear what you're attempting to do in your 10 bullets and participate? Because, as you know, you even have a limit on the numbers that can come on today. But if the community could be more actively involved, quarterly would be nice, monthly, but at least quarterly.
I'm going to respond, Betsy. Thank you. That's amazing. A couple of quick things. One, yes, please keep that open until further notice. Thanks for continuing to share it. We are having rolling recruitment for community members to participate. And second, Betsy, let's have you and Stefan also follow up. I love that suggestion. It's been on our minds, and I think we can work towards that. Regarding
And if I could just hop in real quick, Elise. So the enrollment is sort of it's rolling, but we do have a capacity. So we are limited by a budget, because it'd be nice to have a huge pot of money to be able to fund as many community members that want to come on as possible. But we are at a max capacity right now of 12, and right now we're sitting on 9. So there are about 3 open spots left.
Great. Thanks, Stefan. I'm gonna do the unfortunate thing of keeping us on time, so I'm gonna keep us going. I'm moving us to the next slide, and I'm actually gonna do this briefly. So next slide, please. I want to make an exciting announcement on behalf of our policy office. So our policy office has started some new work. They're developing a policy learning collaborative. This was sort of built out of the idea that policy impacts health and health equity. As we have just heard, and as I think everyone's in agreement, communities want to get involved in policy. And we've also heard that folks want to learn more about how to engage and how to effectively participate in the policymaking process. And so in response to that, the policy office developed a policy learning collaborative. And let me tell you a little bit more about that. We can go to the next slide. So the Policy Learning Collaborative is a short series of learning sessions, and it's really focused on health and policy process, right? I'll share a few of those topics in just a second. The policy office led by Sadia McKeith, who's not with us today, is leading this, and they're planning to implement this in spring of 2024. It's going to be 8 sessions over 2 months. They're still figuring out the location, but they're hoping to recruit 15 to 20 community members to participate. Similarly to the LHIC, any community member participants will be reimbursed for their time, but more will be coming out around recruitment later as this develops. I want to say that the Local Health Improvement Coalition is going to collaborate with the Policy Learning Collaborative. So we will be bringing them into our monthly meetings. We'll continue to make announcements here, and we want to support their recruitment of folks as well. Let me very quickly, just to keep us on time, share a handful of the topics that they're planning to do some training and education around. So first is the overview of why policy is important. They're going to talk about the social determinants of health, a government 101, how an idea becomes a law, engaging in the policy advancement process, policy change through stories and media, accountability, and evaluation. So they will be going through that. And I want to just also finally note that we did bring them to the LHIC, and the community was able to give feedback on their topics and process. And so hopefully that was also community informed as well. But more will come on this topic, and we look forward to your all's engagement and participation. So with that, I'm going to wrap up the health department announcements, and I'm going to hand it over to our priority areas. I think our first group is the social determinants. I think Kiana's up first, and I just remind you guys to please announce your name before you go, and pay attention. I'm going to try to keep us on time. So Kiana, take it away.
All right, well, next slide. Hello, everyone. I'm Kiana Mayo. I'm one of the co-leads for the Social Determinants of Health work group, along with Dr. Teresa Leslie. And we have many active and dedicated members who are very passionate about the work, and we are continuing to recruit community members, and soon we will be introducing the youth members. Next slide. Thank you. All right. Our goal is to improve the health and well-being outcomes by addressing the social determinants of health. And one thing we like to do in this group is to keep an open mind and to work outside of our own silos. And our objectives is to improve the food availability, access, and utilization by fostering engagement between farmers and community. And we also have to, keep in mind that the farmers should lead in this case. For number 2, we are increasing the knowledge of healthy food through community education. And one thing we don't want to do is try to reinvent the wheel, because many of the farmers, if you have not gotten a chance to read the farm report that me and Dr. Leslie did, I would strongly encourage you to do that, because you'll learn about a lot of the work that these farmers are doing. Some bring on the community members, they have educational classes, teaching people how to make healthy foods very tasty. And lastly, we want to assist in the growth and development of this word is just escaping me. Development of a suitable
Sustainable.
urban and thank you.
Sustainable.
Thank you. Sustainable urban agriculture industry in Baltimore City to improve the economic stability of Baltimore City residents. And this also goes back to education. And I think me and Stefan might have had the same idea with our proverbs. And what came to mind for me in reading this is that if you give a man a fish, you will feed him for a day, but if you teach him how to fish, you will feed him for a lifetime. And with that, I will pass it over to Dr. Leslie.
If you go to the next slide, whoever. Oh, so our continuing work, we're really working hard to get funding. And we are now preparing some USDA grants, and we have submitted an NIH grant. But this is kind of a new field, incorporating the work of food systems into public health, since public health has become very, very clinical. So we're talking about moving it from the hospital or from the clinic and actually going into the communities, farms, gardens, community organizations, because you need all of that to get people not only, the access to the food, but people need to eat the food. And a lot of the work, I think this has been mentioned, is already happening in these communities. It's just about tapping into them and finding the resources, which is where the funding comes from. So we're trying to align our work with the other working groups, diabetes and care coordination, because there's a lot of care coordination that goes on these farms that we don't even really acknowledge, in terms of people going to farmers, actually, where can I get this and where can I get that? So there's something that's, there's a lot of opportunity there is also. But we're also paying attention to this 2023 Farm Bill, which is very big. I was watching a committee meeting the other day, 2 days ago. Yes, I see you, Elise. Hi, with your 5. And they made I remember what they said. They said food security is national security. And what's very interesting about this field of agriculture is it's bringing together people that are on opposite sides. It's almost amazing, because everybody needs food. And if you think about food security is national security, then those populations that are the most food insecure are the most nationally insecure. So we have plans, I think, Elise, and we have plans to meet with the Public Health Policy Office, which you just mentioned. But we're also working with other divisions in Baltimore City, so that we're not doing the same work. We don't want to kind of, waste our time doing things and not knowing. So we're trying to communicate. And then finally, and I'm going to turn this over to the very wonderful Richard Staten, because we've been, the past few months since our last meeting, we've been working on integrating youth into the work group. We're finished with our training, and I'm going to let Rashad talk about that. So take it away, Rashad.
Awesome. Good day, everyone. So, as Teresa had mentioned, the LHIC Social Determinants of Health Work Group is ready to go into our Tier 2. You can move on to the next slide. And our Tier 2 is fully integrating the designated youth representative to work on this work group. We have successfully completed 2 adult trainings of those that opted in, and thank you for those that have participated in those trainings. We learned much from you all that have prioritized the values, our lenses, and our approaches of engaging young people, from advancing youth engagement to sustaining and supervising effective youth and adult partnerships. Our young people, as a part of the training and onboarding, has successfully completed their Summer Leadership Institute, in which they learned the soft and hard skills of presenting, engaging, and being vital stakeholders at decision-making tables. To the point that we have identified 3 to 5 young people that will start to work on the social determinants of work group starting by next month. To complement the accessibility to both youth and adults, the work group has committed to changing our meeting dates to either take place on Thursday afternoons or to host hybrid meetings either on professional development days, or what City Schools calls mindfulness days, in which young people either have a full day off of instructional learning or half a day off of instructional learning. To also complement youth friendliness, we have taken the approach to assess and schedule planning meetings that will allow us to be mindful of language, content, and how we engage young people and adults at these decision-making tables. This is the tier 2 of a 3-part phase, in which is integrating youth into this intergenerational approach. After we have successfully integrated the young people on this particular work group, CLEAR, along with other community-based partners, will then identify additional young people that will work on the other culminating LHIC work groups, being diabetes, kid coordination, and others as well. We will go through these phases and allowing our young people to give us impressions and feedback and considerations, both from youth and adults, through surveys, some assessments, and peer-to-peer empathy interviews, so that we can learn from it and go towards replicating this framework, that we can start to see youth representation across the larger LHIC efforts. You can go to the next slide for those that want
Rashad,
to. Please.
Rashad, sorry to interrupt you, but may I ask you to please speak up? We've had a request to increase your volume.
Got it. What you all see on this particular slide are the proposed meeting dates that will complement young people to be a part of the moving forward for the social determinants of health work group. These will not conflict with their learning instruction time, which they'll be on professional development days or mindfulness days, which are half a days, or Thursday evening days. Our young people have already completed a doodle poll notating their availability. The same doodle poll will be shared to the social determinants of health work group and the adult service partners and agencies, so that they can opt in on which days are best fitting. Again, we were making sure that we'll bring 3 to 5 young people to work on this board, and that'll complete our tier 2 of phase 1 of implementing this intergenerational approach of the LHIC, but specifically with the social determinants of health. By January or February, we'll start to try to integrate more young people on the larger work group committees as well. That actually concludes my portion of next steps and action items for the intergenerational collaborative approach for the SDOH.
And that completes our presentation in general. Thank you.
Thanks. Any quick questions? We've got 30 seconds. All right, great. Well, then we're going to hand it off to care coordination. Diana, if you want to take it away, please introduce
Sure.
yourself.
Sure. Good morning, everybody. I'm Diana Quinn with MedStar Health. Next slide, please. Next slide. Just going to share a little bit of our journey at MedStar Health with social determinants of health screenings. So as you can see, we prioritize social determinants of health through our community health needs assessment back in 2015. And as part of that, we felt it was really important to partner with a web-based directory. At the time, they were called Aunt Bertha. Now we all know them as Find Help. So we were one of the first health systems to invest in that web-based platform and really developed a good contact list for community organizations. Moving along the lines here, in 2018, we created, through the Baltimore Jobs Program, Community Health Advocates, and really embedded social determinants of health screening as part of our workflow to prioritize what does the team work on first. So it was just part of our standard protocol. And once again, we saw SDOH prioritized through the community health needs assessment. We pivoted for the Baltimore region so that we could collaborate with the city on the Accountable Healthy Communities grants and pilots. So we did that for a few years, and then everything got scaled because of COVID-19. Everyone at the hospital wanted to know, where were these resources? How do we do it? So our small little project within our team really scaled. We were able to integrate our social screener as well as a web-based directory into our electronic medical records. We put the web-based directory on our community-facing website as well as our patient portal, so everyone had access to resources. And then really started navigating through Z-code integrations, working with our quality and safety coders. And then we got the announcements of the regulatory CMS requirements of all inpatients to be screened in 24. Next slide. So just sharing with you what is our MedStar standard social determinants of health screening that's already embedded. So Our first question is newer, part of the quality and safety team. Their recommendation was really to access if patients willing or able to complete the screening. We have a pre-screening question that takes place. And then if the answer is yes to the broader, I'm having a hard time finding food, housing, transportation, utility, medical care, and employment, then it activates a series of other questions to really dive in deeper to which social need they need resources for. And then we capture any referrals that we do within the electronic medical records. Next slide. So this is our recommendations as we're trying to figure out and navigate these new CMS regulatory requirements. On our side, on the community health side, we really are expecting an avalanche of referrals to come our way. So how do we triage? How do we navigate that so that our team doesn't get so overwhelmed? So these are proposals, not final yet. We're still communicating it through the 10 hospitals in the system, but this is the general idea. If a patient declines, no further action. If no social needs were identified, no further action. If there's low risk, a score of 1, we are going to share with you what we're thinking of independent navigation. We're looking into the innovation centers to do text messaging or email the web-based link that we have so people can navigate on their own, as well as introduce in all discharge packets a QR code so that if they discharge in the ED, inpatient, outpatient, regardless, they'll have a resource within their discharge packet, as well as a flyer giving them the link 211 as well as the QR code to our web-based directory. And then we're also looking to incorporate telehealth technology coordinators to really do some bedside computer literacy assessments to see if that's even an option for them. Then with our moderate risk and high risk, the idea is a secondary screen with our acute case management upon discharge planning and really seeing if supported navigation is needed depending on their discharge. If they're going home independently, if they're going home to a rehab facility or a skilled base. So again, really looking into this, being thoughtful and mindful of the resources we have on hand, along with how can we support and empower the community to find some of these resources as well. Next slide. So independent navigation, again, just showing you some visuals that we're piloting because we have a few months to get this right. So we're piloting right now. And really the goal here is empower the community to locate resources through our what we call MedStar Social Needs tool, which is powered by Find Help, as well as our utilizing our investment, right, through the website, through the patient portal, and then even chat box or text messaging for those low risk individuals so that they can identify those resources and connect on their own. Next slide. Supported navigation with care coordination and referrals. Again, anything positive the plan now is for it to land in acute case management or transitional care managers. They will play a vital role to identify these vulnerable populations and again, really support them during their discharge planning. Again, utilize our social needs tools that we've already shared, as well as those that are going home independently, those complex cases, those that probably need more hand-holding, developing referral systems to our community health workers, to our peer recovery coaches, to our different navigators, as well as other resources across our hospitals, and really be the eyes and ears of the hospital after discharge, really helping them with short-term and long-term application assistance. And then, yeah, so that's kind of what we're thinking. Next slide. Care coordination opportunities. We have been a partner with the city for many, many years. We will continue to utilize and work with CRISP for data sharing collection, as well as utilizing the social determinants of health tab that we were a pilot site for. We have a long-term relationship with Healthcare Access for Maryland, so our CHAs are very familiar on that referral process, as well as making sure we have strong connections with MCOs and ACO care managers so we can do some like warm handoffs to those partners, as well as Department of Aging. continue sharing and promoting across Baltimore City any lifestyle management workshops that are being taken place, so DPP and Living Well, others. And then, of course, submitting 311 requests to meet community needs as we identify those, as well as promoting 211 United Way programs. As we know, not everyone has a cell phone or is able to use a QR code. Want to make sure those are there. Next slide. I just want to share, this is hard. So I'm hoping that I'm speaking on behalf of the other hospitals. This is a big lift, and we have been on this journey for some time, but the scaling of this involves nursing in inpatient settings. So getting their buy-in, going to the councils, updating their workflows, their electronic medical records so that they can do the pre-screening question, and then developing automatic referrals so that case management is aware, and then figuring out that whole triage of referrals so that one team doesn't get avalanched with all of the referrals, managing that, and then closing the loop. This is a heavy lift. So just wanted to make sure everyone's aware of that, but we are being mindful and thoughtful of the process, the resources we have, and really creating a collaborative environment where we can communicate, where community health is working very closely with quality and safety, who is leading this at the system. But again, really making sure that everyone's fully aware, trained, and that we have the infrastructure available for reporting at the end. Last slide. Thank you. Whew, I did it. I did it. Any questions?
Looks like Lisa Starkey has a question. Thank you, Diana. Nice ending there. Appreciate it. Go ahead, Lisa, please.
Great presentation, Diana. Excellent. If you ever want to talk offline, we have semi-operationalized this, and I can tell you like our failures, like what doesn't work and what has worked so far on a couple things. I don't know that we've scaled it this exact height, but between MD-PCP and then those patients coming into the ED, and then really with Chris starting to hold us, or CMS starting to hold us accountable for the Medicaid lives, we're kind of working through this too. So if you ever want to really contact me offline, my email's in the invite, and I welcome you to have those kind of conversations with me, because I can tell you some, like having the RN bedside managers, like, or having the RNs in the ED. Currently, right now, we have the RNs in the ED doing SBIRTs, but the case managers doing SDOHs, and the SBIRTs aren't getting done because the patients are leaving by the time they actually interact with a bedside RN in the ED, right? Because they have to go through triage and they have to go. Mm-hmm. So we're switching that and doing SDOH SBIRT in the waiting room now.
Oh,
so that way they don't leave.
Yeah, absolutely. And let's definitely connect. I think there's some good lessons learned.
And we'll literally, if they pop positive, we'll put a peer recovery person right in the waiting room and talk to them right there, because we'll get the people that just don't want to wait and leave, because the wait times are 2 to 4 hours sometimes. So anything like that, please feel free to reach out.
Absolutely, will do.
Thank you, Lisa, and thank you, Diana. Before we move on, just 2 quick things. One is just a reminder to our healthcare partners that we have an every 2-month meeting around data sharing that the health department is leading for the LHIC. Lisa, Diana, if you want to talk about topics that we could bring to that meeting to further this conversation, we would love to support that. And then second, relatedly, Betsy Simon reminds us again that as this work is continuing to develop around social needs screening, connecting people to the resources that they need, it's important that we bring in the community voice to that process. And again, to her recommendation earlier, the LHIC could facilitate bringing those folks in the room and get some feedback about our work. So just highlighting that out of the chat, I think it's a great point, Betsy. Thank you. With that, I'm going to move it on, and thank you, Diana. I'm going to move it on to our diabetes group. So we've got 3 presenters. We've got Pam, Alice, and Michelle. Pam's going to start us off. Please introduce yourself, Pam, and reminder to this group, for the entire presentation, you all have 15 minutes. So Pam, take it away. Pam, you're muted, just so you know.
Yes, thank you. I'm going to move my window over here. Yeah, so I thought I was going to be going after Alice. So I will preface some of this with what is in their excellent presentation, because we were trying to sort of streamline this. So I represent Ascension St. Agnes and LifeBridge Health. We are in a regional partnership. We have 5 targeted zip codes, 21207. 21215 and 16, and you can think of them as surrounding Sinai Hospital, since we're all familiar with the Baltimore area, and then 21223 and 29, which represents Grace Medical Center, and as well as Ascension St. Agnes, where I'm sitting right now. So next slide. So the purpose of our grant is to expand access to diabetes education and support, as well as diabetes prevention. And that's the same as the other regional partner that's going to present. We offer at Ascension St. Agnes a diabetes prevention program, and we offer diabetes self-management training and support at Ascension St. Agnes, at Sinai, and at Grace Medical. Next slide. These are some of our locations where we actually offer our services. The next presentation is going to get a little more involved as far as what these services entail. But right now we are looking at a diabetes prevention program. If you look at that map, you can see that the high location is the JCC right next to Sinai. And we have other community partners around the city. DSMT, that top button there is going to represent Sinai, Grace Medical, and then we are currently offering DSMT at our Ascension St. Agnes campus, as well as our first embedment into a primary care office, which is at our Catonsville office, and we are looking to expand into a primary care office on campus. That seems like a small thing. It's literally, I can see it out of my window, but we've seen that access to care is a huge barrier in the populations that we are all trying to serve. So offering these services at their providers' offices makes a huge difference in a patient's willingness to take advantage of the services. So we are looking to expand in order to meet our population where they are and make it as easy as possible. The educator at Catonsville keeps saying, all my patients are on time, because that is not typical in diabetes education space. But when we're meeting them at their doctor's office, they know exactly where to find them. And we have funds to lift them there as well. So that all works out beautifully. Next slide. So our education successes, we are just now, as of 2 weeks ago, fully staffed. So when you've heard me speak before, I've mentioned staffing challenges, up one side and down the other. But we have a total of 8 diabetes educators across our system and 5 DPP coaches. We are looking to expand our model into the primary care office. For those of you familiar with the Maryland dilemma of regulated and unregulated space, just to give you an idea of diabetes access issues, our fees in an unregulated space, which is where we are operating our Ascension St. Agnes facility, as well as the Grace Medical facility, it is 1/10 of the cost. So previously, for a 2-hour visit, patients were, when they saw the bill, it was $1,100. In unregulated space, it's literally 1/10 of that. So for Medicare patients, which is a huge part of our target population, for those of them without a secondary insurance, this is how we get better equity in this space, because they're not responsible for the facility fee. So our success has been largely, what we've been doing well is getting us into the primary care offices, which I already mentioned. We do have some struggles with getting our RDs credentialed, because the billing piece of in regulated space, there are some barriers there, but we found some workarounds. And we are moving forward. Our retention has been excellent. We have a 96 completion rate of our classes right now, and 100% of our participants report positive changes in diabetes distress and improved confidence in managing their condition. The next presentation is going to have some great patient stories for you to look at. Next. Food access. So one of the key components of our partnership with LifeBridge is that any participant one visit for DSMT or DPP. If they live in one of those targeted zip codes, which I mentioned, gets a phone call from the lovely Nicole, who was on our call today, to ask them to set up coordination of food benefits. So we have changed it over time, and now we're up to about 6 months of food support. I will tell you, I would love this benefit. But people are very suspicious of this benefit, and we do struggle with convincing people that this is for realsies, because when we call them and say, we want you to engage in this class and we have this food benefit, sometimes their first thought is, how bad must this class be that they're offering to feed me for 6 months just so I'll attend? So we sometimes think, this is fantastic, everyone's going to want this. But an important part of our work is building trust in the community, because it just doesn't always translate the way we hope it will. Next slide. So this is just an overview. I mean, you guys can just look at this quickly. We basically have a 12-week option of something that's a little more tailored to send out to people. And then after that, they can kind of graduate to the Giant Food Program or the Tangelo program. We're also, as part of this grant, working with the virtual supermarket to get patients in senior housing grocery delivery, which we actually cover the cost of. The thing that patients really do engage well with is the Giant Food. It is a beautifully tailored program. Nicole actually works to coordinate their bonus card with the program, so nobody knows they're using the program. When they run their card at the beginning or the end of the transaction, it basically says LifeBridge discount, LifeBridge discount, LifeBridge discount, and that takes off as much as $80 a month. I mean, that's the benefit, so up to $80 a month of any fresh or frozen fruit or vegetable. And patients that actually engage with this, they love it. And just as another aside, you don't have to still be enrolled in the program in order to get that benefit. The first visit triggers all of this. Next slide. So this is just an example of some of the patients we've been able to serve. The zip codes are down there again as a reference. Next slide. And people love the food. So I have a slide on food survey feedback, but they love it. So that's a nice little quote where the fruits and vegetables were outstanding, because fruits and vegetables are outstanding. Next slide. And people like it. They like it. They feel like it helps with their weight loss goals. I'm a clinician. One of the things that we have noticed, as a broad thing as far as diabetes education, diabetes prevention, is that when I first got involved in this field, we only talked about what you couldn't eat anymore. And now we know, with all the research, that the focus needs to be on high quality foods and getting these patients to really have access to and incorporate fruits and vegetables in their daily meal planning. And I think that's it. Oh, it says the next slide is how to get in touch with us. I'm in the chat. My last name begins with, oh no, we need your support. We need your support. This is the next slide. Only 1 in 10 people know they have pre-diabetes. It is very difficult to do direct to consumer marketing because no one thinks we're talking about them. We're limited to seeing people who have a verified diagnosis. This has been a huge challenge. So if you know someone who has pre-diabetes, please encourage them to reach out to one of the regional partners, ourselves or University of Maryland and Hopkins. Help us normalize people knowing their glucose status. Diabetes is 1 in 4 healthcare dollars, and most of that is cardiovascular disease. The A1C only gets us to microvascular complications. So we really need the fruits and vegetables and the exercise, and that's what our education provides. Help us normalize every person with diabetes accessing their diabetes education team, because everyone in the city has someone that they can reach out to. It's just a matter of encouraging people to get help. Education questions can come to me, and food access questions can go to Nicole. Hopefully that was fast enough for you guys.
Thanks,
Elise,
Pam.
I shouldn't be first.
Okay, no problem. I'll make a note.
I'm just kidding.
Pam,
I just talk and talk and talk.
Pam, you have a couple questions in the chat for you. I'm going to let you answer those in the chat. We'll come back to that. I want to give some space to Alice to start her presentation. Thanks, Alice.
Hey, thanks everyone. Good morning. And I'll try to answer Phyllis's question too. Pam outlines it nicely, and I want to say that first, let me introduce myself. Actually, I'm Alice Chen with Johns Hopkins Health System. I represent Baltimore Metropolitan Diabetes Regional Partnership, which is both Johns Hopkins Medicine and University of Maryland Medical Centers partnership. As Pam mentioned, our partnership and Pam's partnership are one of two in the Baltimore City area that's funded by the state of Maryland. So this is a funding mechanism from the state to help us build the two programs that Pam mentioned, the DPP and the DSMT. There are 5 regional partnerships similar to ours in the state. So 5 of us, and our 2 represents Baltimore City. Hope that answers the question. Next slide, please. So we thought, and we try to coordinate this with Pam so that we're not sharing the same information over again. And so we thought we'd start by describing a patient story for DPP. Click that. So this patient member came to us. We do a lot of events, recruitment, health fairs, and this patient came to us one day through our fair, wanted to learn more about the diabetes prevention program. And as she learned more about it and participated in it, we helped her along the way to get diabetes A1C testing and found out that she was in the pre-diabetes range. Next click, please. So along the way, when she started the program, which is a 1-year-long program, a little bit about the DPP, I shall say, that it's a 1-year-long evidence-based program that focuses on lifestyle change, mainly helping participants who are at risk for type 2 diabetes or diagnosed with prediabetes to sustain healthy choices, healthy lifestyle choices, achieve weight loss goals. Those are a couple of the priorities. So in the short 3-month time frame that she participated in DPP, as you see, she has successfully achieved a good dose of weight loss, or weight loss improvement, I shall say, and an improvement of her A1C. So our programs, both ours and Pam's DPP program, are certified by the CDC, which means that
Alice, we're losing you, just so you're aware. Alice, I think your connection maybe is poor. Let's give you one more time, one more shot, and then we might come back to you. I'm gonna try one more time.
Yeah, she's looking frozen.
Better.
Okay, let's come back to Alice. I'm so sorry about that, everyone. Alice, we'll come back to you, and then Matt, if you don't mind advancing to Michelle's slides, and then Michelle can take it away. Thanks.
Hi, everyone. It's great to be here, and thank you for the warm welcome today. My name is Michelle Peralta. I will be the LHIC manager, and I'm also a grant director here, which leads into our updates for the diabetes work group. We were able to secure and get funded for a CDC grant to support the great work the regional diabetes groups and partnerships have been doing, and that is called a strategic approach to advancing health equity for Baltimoreans at risk for diabetes. Next slide. Great, and we actively pursued this grant because it's in alignment with our 3 key priorities for the LHIC. So this grant was awarded on June 30th. We have started the work, and I'll give you that timeline soon, but it is a 5-year grant over $5 million over 5 years, about $1 million each year, and we'll be addressing barriers to diabetes prevention and reduction. Ultimately, the goal is to prevent and delay the onset of type 2 diabetes among adults with prediabetes, as well as improve self-care practices, quality of care, and early detection of complications among those with diabetes. So again, all this work is to support our diabetes regional partnerships. Lastly, the last goal is to reduce health disparities and achieve health equity. Next slide. Great, so For year one, we do have a very specific goal, and that is to increase our enrollment and retention of priority populations that we'll discuss and show you into the DPP programs. So to start, ultimately our huge objectives will be to outreach to about 49,000 residents in neighborhoods that are more likely at risk for diabetes. And out of those 49,000 residents, we're hoping to refer about 4,000 residents to the DPP programs. This is just a small timeline for you all to see. The project did start July 1st when we were awarded the funding. We are currently in the design phase and outreach development phase, and we'll break that down a little bit more for you, but working very closely with, I said, the diabetes regional partnerships on this. And we'll leave it at that and show you kind of our milestones that are coming up. So as you can see, there's some pieces that have been completed. We have gathered all our requirements. We are working on our evaluation program and plan. We're currently in our design phase and moving into our outreach development phase. In our design phase, we were able to build a geographic map of Baltimore City, highlighting our diabetes risk score. This took into account 7 health-related factors as well as 2 geographic factors, and that will be the next thing I'll show you in a minute. But ultimately, too, we are continuing to have our monthly meetings with the diabetes work group. And what we'll do in that agenda is shift it a little bit so that we can continue to assess, refine, and improve the quality of the CHW outreach and referral strategy with our DRPs. Next slide. Awesome. This is our map that we have begun in our design phase and outreach strategy plan. It's an overview you can see of our Baltimore City census tracts by our diabetes risk score. As I said, we took in about 7 health-related factors and 2 demographic factors. You'll see the darker the dot, the higher the diabetes risk score. And let's go to the next slide. So this is just a big overview of the city. And what we were able to identify were about 22 census tracts had a high risk score of 80 or higher. So the max score is 90. And within those 22 census tracts, we identified about 41,000 people, which ultimately is our goal for year one, which again was 49,000. So we're basically there. And when we broke down those 22 census tracts, we found clusters throughout the city. And that will be ultimately what we're hoping will be our outreach strategy for year one. We'll focus on 6 months in West Baltimore, so that cluster A, another 3 months in East Baltimore, known as cluster B, and then 3 months in the Pimlico Park Heights area, which is north in cluster C, and then below in Cherry Hill as well. All right, so again, we're kind of still in our design phase. We will continue to give you updates on where we are on the project and work with our DRPs as well as the diabetes work group. If you have any questions, feel free to enter them today into the chat or reach out to me directly by email.
Thanks, Michelle. I want to see if Alice is back on. I also want to note that we've got about 10 more minutes and we've got 2 more presentations. We've got a question in the chat. Please go ahead. Thanks, Michelle. Someone on the call had a question. Do you want to come off mute?
Yes.
Yes, ma'am.
This is Marguerite Woods. Hi. Thanks for the presentation. As a stakeholder, this arena is relatively new to me, so there are a lot of acronyms. I'm not following all of it. When you're talking about the slides, I don't see, and I'm on the phone, so I'm sure there are other people on the phone as well. So just being mindful that we're not seeing the slides. So if there's information that you want us to know about, you might have to really highlight that verbally.
Thanks for the reminder, Marguerite. And we'll share this out in text only and definitely continue to strive to present our slides more visually so that we can make sure we describe what's on there. But thank you for that feedback.
Sure.
I'm going to move us on. I think I'm going to go ahead on to this community spotlight, and then we'll come back to Alice and her team at the end of this. And so let's give some space to Jeanette North, I believe, who will be presenting for us today. Jeanette, if you're with us, could you introduce yourself quickly and then begin your presentation?
Sure, thank you. I'm Janet North Kabor. I am the Community Program Director for the West Baltimore Rich Collaborative. I oversee all of the community partners. Joining me today is Assunta Johnson, who is also a Community Program Director who oversees the healthcare partners. And we're also joined today via phone by Dr. Dean Yolanda Obalu, who is the principal of this project. And the funding is provided by the Maryland Community Health Resources Commission. And we can go to the next slide. Thank you. You can go to the next slide, sorry. The West Baltimore Rich Collaborative focuses on reducing isolation and inequities in cardiovascular health by addressing hypertension, social determinants of health, and social isolation. And like many others, we're working towards building stronger, safer, and healthier communities together. And as a lead institution, University of Maryland School of Nursing supports groundbreaking research and scholarships that enhance the field of nursing, influence modern healthcare, and spark new thinking about the ways we care for each other as a society. Our project is entitled the West Baltimore Rich Collaborative, and it builds on that foundation to incorporate multi-sectoral collaboration across community-based organizations, faith-based organizations, academia, hospitals, and hospital-related entities, and 2 federally qualified healthcares that you can see listed here to the right. The holistic vision of the Rich Collaborative values bidirectional learning across, between, and within health organizations, communities, community and faith-based organizations, and individuals. The goals of the Rich Collaborative are to bring forth innovation for health equity and to strengthen and synergize current resources across organizations to improve health outcomes for Baltimore City residents, with the focus being on West Baltimore. Next slide, please. And so as you can see here, there are these are our key community engagement partners, and their roles are essential to the sustainability of our program because they have their fingers on the pulse of the community and are the frontline advocates for residents. Their roles consist of continuous bidirectional communication, engaging and referring clients to participate in interventions within the West Baltimore Rich Collaborative. Along with the other partners, they actively participate in regularly scheduled governance committee and subcommittee meetings. They facilitate various community health and social outreach events. They also serve as trusted entry points to the West Baltimore Rich Collaborative Network and refer patients to resources within the network. They provide us with opportunities for youth advocates and also community outreach workers. They facilitate various types of support groups, whether it's grief loss, racial and social trauma, isolation, dancing, things of that nature, and other fun and creative social events. And finally, they serve as feedback loops for the community engagement process. Next slide, please. So the West Baltimore Rich Collaborative uses 5 overarching strategies to meet these goals. And one being that we convene a health equity learning collaborative that enhances the care coordination across partner organizations, increase access to primary care through nurse managed facilities and community health worker referrals, extend mobile health in the community through mobile health programs, implement a community health worker model to strengthen the care coordination, to address some of the social determinants of health and social isolation needs. And finally, they implement primary and secondary prevention events to reduce the risk and manage hypertension and support groups to address social isolation. And the next slide, we talk about social isolation and we talk about the strategies that the West Baltimore Rich Collaborative has and how they're aligned with the 5 strategic goals of the Maryland Health Equity Resource Act. And the first one being reducing health disparities by reducing the racial disparity gap, and then improve health outcomes, increase access to primary care, promote primary and secondary prevention services, reduce costs, admissions, and readmissions. And we know that when we work together to reduce hypertension and social isolation by connecting people to the social determinants of health resources that they need, we all achieve our goals of building safer and stronger, healthier communities. And with that, I'll turn it over to Assunta to share more about our process.
Janet, good morning, everyone. I'm Assunta Johnson. I'm sorry. So our community outreach workers are working through the process of referrals to engage with patients. I'm so sorry. So sorry. Oh, my apologies. Through referrals from nurse-led clinics, health organizations, community events, and mobile health cares to enroll individuals into our program. Once they identify their social determinant of health needs, we're connecting them to resources, providing them with blood pressure cuffs, and connecting them to anything that they need from, for example, I'll take food stamps as one of our major things that people identify as needing help with. We're not only just making sure that individuals are receiving the information, they're also learning, they're also being assisted on the process of going through the application, making sure that it's submitted, doing the follow-up work by calling in, and we work with them until they receive their card or their rejection letter, and then help them with next steps. In the meantime, we get them emergency food resources that they can take advantage of until they get through that process. So our outreach workers are really really working on these referrals to make sure that the individual client is really serviced. Next slide, please. And this outlines more of that process. So before working with that outreach worker, we have patients that are dealing with a lot of different barriers and challenges to accessing health and other resources. They go through the enrollment process, which is a short survey and registration. They begin working with them, and then we connect them to those resources. And then the follow-up process can happen anywhere between 30 and 60 days after you've met that client. So it depends on the client's specific case on how long it can take. Next slides. So how is it sustainable? So our collaborative, as you saw in the earlier slides, they're made up of a diverse network of partners who bring in multiple ways to address the client needs. Recently, we all met up at Roberta's house to host an event where we all brought our expertises together and we're really able to address different clients' needs on different levels. So we're also working with the integration of the West Baltimore Collaborative Partners. The sites will be a sustainability level. I'm so sorry, can't get this together. Lever, and then we're having the community benefit organizations who are also working and engaging with our large institutions and partnering to work on different initiatives as well. Our nurse-led clinics that are all throughout the community, they are all each partnered with a healthcare organization. They are working to address client needs, especially our clients who have been discharged to the ER, returning to their homes, making sure that they're connected with primary care providers at times, and really their case to make sure that they're fully taken care of. Next slide, please. So what's our current impact and what does that look like? We currently have established 4 nurse-led clinics, McCullough Homes at City View with the University of Maryland Medical Center, the UN Community Engagement Center, the Coppin State University Health Clinic, and the Garwin Family Medical Center. They are all robustly working with a target population of patients where they're really addressing their needs, where they live, work, and play. Our mobile health has impacted a large amount of the Baltimore City population, where we have distributed over 275 home blood pressure cuffs. We've taught individuals on how to use it. We check in with them on a regular basis to make sure that to see what their numbers are doing. If someone needs more assistance, we're connecting them to primary care providers, and we're also making sure that they can manage their blood pressure robustly by taking care of their overall health, physical needs, and other things like that. To date, we've attended over 80 health prevention community events related to high blood pressure management, and that list continues to grow. For social determinants of health and social isolation screenings, 65% of our screen participants have reported having a social determinants of health challenge, and then over 800 social needs have to date been identified, and we're currently actively receiving support from all of our partners to address that. Next slide, please. So just some survey feedback from the words of from the mouths of our patients and our community members, just different from positive anticipation to trust and appreciation of gratitude for our entire partner collaborative, but also our outreach workers and the amazing work that they have been doing. It's just a lot of gratitude that goes out when we're able to work with these patients for a lengthy amount of time to really address their needs. So we are continuing on with the journey to make sure that we will be there and Rich will continue to grow. So as you can see, I won't read from word to word because I know we're out of time. Next slide. And if you're interested in partnering with us or wanting to any of our support groups at your event, host a workshop, please reach out to myself or Janet North Kabor here on the screen. You have our contact information. Thank you.
Great. Thank you both for that presentation about the Rich Collaborative. And thanks everyone for staying on just a couple minutes late. So we're unfortunately not going to have time to get back to Pam and Alice's diabetes presentation, but we will share the notes in the meeting. Excuse me, we will email out the notes and the slides to everyone so you have access to that. You can also join us on our monthly diabetes meeting where you can learn more about the work that's happening in diabetes as well. We want to make a little bit of space for any community announcements. I would like to first make one quick announcement. There are several folks on this call that we'll be sending out a survey to ask about your participation. Please keep an eye out for that and please fill that survey out as soon as you can. We'd like to know about your experience. And then I'd like to open it up to anyone who would like to give a community announcement. And it looks like Dr. Bronner, please go ahead.
Yes, I cannot let this meeting go by without saying that at Morgan, we're so pleased to be the recipient of the HRSA Maternal Health Award that is community engaged. And so look forward to hearing a lot more about it. It is in total a $53 million approach for 16 universities. So we're looking forward to engaging with you all and all that we're doing together to make this a big success. Thank you.
Wow, Dr. Bronner, amazing news. Thank you for sharing. Any other? Katrina Brooks, please go ahead.
I just want to share that October 20th is the Youth Health and Leadership, Sexual Health and Leadership Conference at the Lord Baltimore Hotel. This year, we are focusing on youth-adult partnerships, so we invite you all to come out and be a part of this citywide event that involves young people 14 and over. The health department, Maternal Child Health is co-sponsor of this event, which happens annually in partnership with R&D, which is Rebecca Atnafu's organization. So please come out and join us. Put it on your calendar, October 20th. Thank you. It's from
October 20th. Thank you, Katrina.
9:30 to 3:30.
I just wanted to add that STI and HIV are also sponsors of that event.
Tell us the name of the event and the date and time again, please.
Youth Sexual Health and Leadership Conference. It's at the Lord Baltimore Hotel, October 20th, 9 to 3:30.
Thank you.
Do you have a flyer or a link that we can put in the chat?
Yeah,
So
I can
capture
send
that for people.
I can send it to you.
Great, thank you.
You're welcome.
Crystal Parker.
Yes, hello. Yes, I just want to announce that through a COVID grant through my neighborhood association that I got, we are sponsoring an event tomorrow. It's called Navigating Life After Incarceration, COVID and Trauma. It's going to be at the Reginald Odom Playground, and it's from 1 to 4. I can see if I can figure out how to put the flyer in the chat.
Crystal, you can email it to us as well and we'll share it out. It's tomorrow at what time? Tell us again the name and the time.
It's from 1 to 4, and it's at the Reginald Odom Park at 3100 Pressman Street from 1 to 4. And it's through a COVID grant, COVID and social determinants of health grant.
Thank you, Crystal. Any other announcements? We're about 5 minutes over. Thanks for everybody who stayed on. Any other announcements for today? Thanks everyone for your time. Thanks to all our presenters, and we appreciate you all very much. As usual, we will share out all the notes, all the flyers at the end of this in an email. I want to just remind Crystal, Betsy, and Marguerite to follow up with Stefan. Stefan will reach out to you and we'll connect on some of your feedback. Thanks for Janet and Asante for their presentation, and thanks to all of our priority area folks for their presentations. Thanks everyone, and enjoy the rest of your Fridays.